I believe that one of the most important things in the regenerative medicine space is to actually treat the pain generator. Hey everybody, so today I want to talk about how I approach these regenerative injections and why it might be different than some docs out there. I know obviously a lot of docs are approaching these regenerative injections the way that I am because these are my colleagues that I've worked with, or they were trained under the same people, or I've trained personally, things like that. But there are a lot of other docs out there who don't take this approach. And so in our long-term discussions on quality, of physicians and injectors and things like that, this discussion just continually comes up. And so I wanted to spend some time just kind of talking you through this. So I believe that one of the most important things in the regenerative medicine space is to actually treat the pain generator, right? This is extremely important because, and here's a kind of more broad example, is if this finger hurts, but you treat this finger, it doesn't matter what you do to this finger's still gonna hurt, right? And so that same concept applies when we're talking about the regenerative injections. If, for example, you have osteoarthritis of the knee, and yes, you have, on imaging, you have osteoarthritis, you have loss of joint space, maybe you've got some osteophytes and bone spurring, you've got some loss of cartilage, whatever it is, right? But if your pain is actually coming from the medial collateral ligament, which is a ligament on the inside of the knee, if the doctor just goes and puts whatever it is inside the knee joint, whether it's a steroid, whether it's dextrose, whether it's PRP, stem cells, an amniotic allograft, whatever it is, if they just put it inside the knee joint and they don't treat the tissue, the structure that is contributing to your pain, the structure that is sending danger signals from the tissue up to your brain and saying, this hurts, do something about it, then it's going to completely miss the mark. And I have talked with doctors who, they do autologous stem cell therapy, they do adipose procedures, and they've had some failures and more failures than other colleagues in the space. And I get talking with them being like, okay, well, what did you treat? And they're like, well, the patient had osteoarthritis of the hip, so I put it inside the hip joint. And it's like, did you treat anything else? And they're like, no, they have osteoarthritis of the hip. It just completely spaces some of these doctors that there can be more going on with a patient's pain than just what you find on imaging, right? And if you've been listening to me for any length of time, I have been drilling home this concept of, that you can't see pain on imaging. You can see structures that could be painful, but you're not seeing pain, right? And so the approach that I take in the regenerative medicine space, it doesn't matter what substance I use. It doesn't matter if I use dextrose, PRP, an amniotic allograft, or autologous stem cells. The approach is what we call a prolotherapy approach, where we are finding the pain generators with our hands, with our orthopedic testing, and then finally with our needle, because finding the pain generators with the needle is a really important part of this process. And we are treating all of those areas. That means that injection numbers are going to be a little bit higher for each procedure, right? And so an example is I recently treated a woman for low back pain, hip pain, and knee pain. And between all of those three structures, there was probably about 20 different actual structures that got treated, whether that was a tendon insertion onto the bone, a ligament insertion onto the bone, a joint space, a nerve, a fat pad, right? And then within those 20 different actual structures, there were 2 to 4 different little locations within those structures that we treated, right? So we call this kind of a peppering technique where if this is the whole area of the tendon insertion onto bone, I'm not just coming in one place and putting it here. I'm kind of peppering all over the place here and putting little aliquots of the solution in those areas to have a more broad effect, to affect more tissue, to get better results. And so that's kind of the approach that I take with my patients. That's what I teach to my students, what I teach to other doctors that I train, and why I think that this approach is getting better results than a lot of other places out there. If you look at the research on prolotherapy and PRP, a lot of the times that this is not happening. And this is one of the biggest criticisms I have with research on PRP, stem cells, and prolotherapy and things is the model of randomized clinical controlled trials on things like osteoarthritis is, okay, patient has grade 3 or grade 4 osteoarthritis, and so we're going to put it inside the knee joint. And it's severely limiting because patients may come back 3 months later and have no change in their pain, and what the research will conclude is PRP is ineffective. Or maybe you just treated the wrong structure, right? Again, if the MCL is what's causing that patient's pain and you put PRP inside the knee joint, it's not that PRP doesn't work, it's that the wrong structure was treated and the physician didn't do a good enough job finding that pain generator. So if you are working with a doc, or you are going through the process of figuring out which doctor you want to work with in the regenerative medicine space, talk to them about this stuff. If your doctor does not know what prolotherapy is, if you say, hey, do you do dextrose prolotherapy, and they have no idea what you're talking about, there's a good chance that they're not familiar with this technique of doing dextrose prolotherapy, or a prolotherapy technique where they're hitting multiple spots, they're treating multiple areas, and it's not just, okay, here's the tendon insertion, go in one spot, done, see you later. Okay, so that's probably the biggest litmus test, is just talk to them. Do they do dextrose prolotherapy? Maybe they don't do dextrose prolotherapy, but they still use those methods, and those are things that you're gonna have to talk to them and try and figure out, and talk with their staff and really try to gather that information so you can make a better informed decision. I hope this helps you guys in your journey for figuring out your chronic pain and finding relief. See you later.